let's look at this. Why are we looking at this? Because fetal growth disorders are the most common issues faced in day-to-day care. And I think decision making in a baby which is abnormally growing is always difficult. And there are tools for assessment of fetal growth and also Dopplers. There's wide variation in practice despite guidelines being in place. New evidence is coming periodically. And then there are screening, diagnosis, interpretation of Dopplers, and also translating evidence into clinical practice. This is what it is. So fetal growth restriction, are we talking of a preventable morbidity or mortality? Because we want to save this small baby. Whenever it is in an inappropriate intrauterine environment, we want to intervene at the right time so that we can optimize outcome. Early diagnosis, appropriate monitoring, and timely delivery. So let's go on to the case study. 33-year-old Primi Gravida is referred for a scan in the second trimester. According to her LMP, she is 24 weeks, but her fundal height appears to be only 20 to 22 weeks. So, Bijoy, want to start?
They just handed me the mic actually.
Pardon?
No, they just handed me the mic. I didn't want to start anything.
Oh, okay. Right. Maybe Shama can start. Okay. She's fundal height is 20-22 weeks, and these are her parameters.
So in this, sir, the biometric parameters, it definitely shows a lesser centiles. But first, I would like to go on to her history. I would like to go on to...
Her history is she's a second gravida.
Yes.
First baby, 2.8 kg, born alive, normal delivery. And all I want to know is, can I label this as growth restriction?
No, sir.
No.
Before that, no.
4
Before
weeks
that,
difference.
dating.
4 weeks difference. So that means at 22 weeks, we cannot diagnose growth restriction at all?
It is possible if her dates were true, if her dates are correct. That I would like to confirm by looking back into her dating scans or at least her NT.
You want her dating scan?
Yes, sir.
So, growth restriction, yes or no? That's all I want.
No, this.
Yes or no? Or maybe? Yes, Vivek?
Not with a single scan, sir.
Not yet.
Not with this.
Okay, so we won't label it to that. So reconfirm with its correct dates. Okay, now I'll give you several choices for reconfirming. Do you want to ask for a report of early scan? Do you want to correct the dates using the current scan? Correct the dates using the current scan only if early scan is not available, or rescan in 2 weeks to see whether dates are correct.
Ask for the report of early scan, sir.
Okay.
We wouldn't correct the dates with the current scan.
You cannot correct the dates with the correct scan. Second trimester is also a dating scan, no?
It is, but not as accurate as the early dating scan. So, is there an early scan?
But if she does not have an early scan, will you do that? Will you accept
yes.
it as a thing? Okay. Right. So you won't correct the dates with the early scan only if the previous scan is not available. Because if that's available, we want to go by that. But many times what happens, they bring the previous scan and we can see a nice crumpled CRL which is there. The CRL is taken in a most inappropriate position. So in such cases, we have no other option to do what is there. Now, here's some dating options for you. So here are some dating options. Which are the weeks you would prefer for dating?
Yeah.
Yes.
Good evening, everyone. Basically, standard teaching is that we have to go by 11 to 13 week scan.
Okay.
And any fetus more than 8 weeks, say about CRL more than 10 millimeters, I think we can take it.
So from 8 weeks we can do that. And if she has only one scan, which is between 5 and 6 weeks, will you ignore it?
Yeah, I'll ignore it.
Because now let me put a very different question here. There is a 4-week difference between her LMP, and which means 1 cycle difference. Okay?
Yeah.
1 cycle difference. And then this tiny little sac was there, which actually says she was around 5 weeks at the time. So, Bijoy.
So I just want to add a couple of points on the dating scan. The first thing is that the most accurate scan is the 8-week scan. So if you have two reports, which happens sometimes, you'll have one CRL report and an NT scan report. And it's very possible that the CRL was smaller for the gestational age, but the NT corresponded. And they came to you at 20 weeks.
Okay.
So in that situation, it's always best to take the 8-week scan and not the NT scan, because the NT scan, because of the extension and flexion, it can create a difference. So if you have two scans, take the 8 to 9 week scan. And another peculiar thing that I have seen is the typing error. The CRL measurement is excellent. Everything is proper, but the typist, when they typed it onto the report, they typed the wrong number, which miraculously was accurate with the LMP.
Instead of 13 millimeters is 1.3
So there are a number of
millimeters.
things that you have to look at when you're looking at a dating scan. It's not just number or the result. Look at the image, look at whether the measurement is corresponding with the type report. And once all those things are accurate, then we can take the 8 to 9 week scan.
Right. So no FGR, wrong dates, yes. So are there any situations where you will always date only by CRL?
When she gives a history of irregular cycles, and you cannot go by the LMP dates.
Pardon?
If she gives a history of irregular cycles, then
Okay.
of course your LMP dates are not very accurate, or she does
So-
not know her last menstrual period.
Is it time to simply, considering the fact we have repeatedly said LMP is not accurate? Okay? CRL is more accurate than LMP is a fact that everybody agrees. Why not we just give up on that LMP and go only with CRL for all patients?
Now, provided we have taken a good CRL, so there are lots of criteria to satisfy when you take a good CRL for dating. So if all the criteria met, of course, yes, the CRL is much more accurate than the LMP.
So should we direct all our training towards taking a good CRL for everybody?
Yeah. And so I think we all have to start giving images then. If
Yes.
we decide today that we have to date by CRL, then we also have to decide that each and every ultrasound report has to go with the image of the CRL.
Right. Correct. So now comes we'll jump into the growth restriction area where there's a definition of the small baby. Is there a real definition for small baby? Is small synonymous with fetal growth restriction? Best fetal parameter to diagnose fetal growth restriction and best method to diagnose FGR. So you can take all questions and then if there's any, yes, we can start from the middle, then we can go backwards.
Well, a small baby
I
is
think-
any baby that does not meet your statistically defined cutoff.
Yeah.
If you say, for example, sorry.
Shama, give it to her. No? Yeah. Yeah. So you can answer all these questions one by one.
Definition of small baby. A small baby is defined from the estimated fetal weight is less than the 10th centile.
Okay.
It's all synonymous with fetal growth. All small babies are not synonymous with fetal growth restriction. There can be constitutionally small babies also. And best fetal parameters to diagnose FGR in fetal biometry is the abdominal circumference.
Abdominal circumference.
And best method to diagnose FGR is the Dopplers, the umbilical MC and urinary Dopplers.
Okay. Do we use Doppler to diagnose FGR? Yes, sir. Raymond.
So yeah, the best parameter to diagnose FGR, I still believe, is estimated fetal weight. Yeah, it's anything less than third centile, and AC is also there. AC anything less than 10 centile.
Right. So now you said about Doppler. The moment you say Doppler, we now have the Delphi criteria to diagnose fetal growth restriction. Can you elaborate on that? Vivek, you want to take that?
Yeah, so the Delphi consensus was as all of us know, there was a lot of confusion about diagnosing FGR, early FGR, late onset FGR. So what the Delphi consensus did was to come out with a standardized guideline so that everybody can follow the same guidelines and make the same diagnosis in the same case. So they have very specifically laid down criteria. What is different from the earlier criteria is that they've also included the fact that you need to factor in Doppler changes as far as early FGR is concerned. And as far as late FGR is concerned, they've added another new criteria saying that if there's a fall in growth centiles, that is also considered significant. So to make a diagnosis of FGR, you basically have a growth parameter, growth criteria, plus a Doppler criteria. So it's a combination of both.
So the question of 10th centile is what we are discussing now. She said below the 10th centile, I'm going to call it as a small baby. But there is a difference between a small baby and a growth restricted baby. So this is the group between the 10th centile and the 3rd centile. So let me ask you a question. If I make a measurement of less than 3rd centile, can I close my eyes and say this is always growth restriction? No normal baby can be below the 3rd centile.
Yeah, that is the other criteria that has been added, because a baby that's less than the 3rd centile has got invariably poorer outcomes irrespective of what the Dopplers say. So for some reason...
So even if Doppler is normal, I'll still call it as growth restriction.
Yes, that is one standalone criteria. If a baby you're measuring a baby and that baby's weight is less than the 3rd centile, or the abdominal circumference is less than the 3rd centile, that itself is a criteria to say that baby is small and growth restricted, irrespective of the Doppler parameters.
Yeah. But then, Bijoy, we used to talk a lot about asymmetric and symmetric IUGR.
Yes.
Are we still using those terminologies now?
No. Previously, it was thought that if you have something that causes growth restriction earlier on, like an insult that happens earlier on, that's when you get symmetrical IUGR. But later on, if it is because of growth restriction secondary to placental insufficiency, the abdomen sort of restricts early and you will get asymmetric IUGR. But that is no longer accepted, because we know that symmetric and asymmetric IUGR can happen in uteroplacental insufficiency. So if you find that the baby is small, extremely small, that is less than 3rd centile, yes, we should classify it as FGR. But at the same time, we should understand that these babies also can have a good outcome. We should not say that they are always bad. They are small, they are growth restricted, they should be put under surveillance, but they can have good outcomes also. The reason why we use the 3rd centile is because when a baby is less than the 3rd centile, then the perinatal mortality and morbidity is in the tune of 90%. It goes above 90%. The chances of losing the child or chances of having a morbidity associated due to that growth restriction. But still, we don't have to write that baby off as yet. I wouldn't say like all of them are going to have bad outcomes. So yeah.
So which means now we have the symmetric, asymmetric has gone,
Yes.
is different, and now we are calling it as early and late growth restriction. Now, in this early growth restriction, I have a problem, right? Are all early growth restrictions due to placental dysfunction? So,
No, they are not. They could
so
be because of...
how do we differentiate that? How
Well-
do I differentiate early growth? Here's a 24, 26 weeker growth restriction, and in one baby you're saying there's placental dysfunction, another baby is saying there's no placental dysfunction.
That's why there is this contributory criteria. If you look at the contributory criteria, they're looking for signs of placental dysfunction. So if you find that the baby is small or less than the 10th centile without any other sign, there is nothing else, especially when a baby is less than the 3rd centile, that's the absolute criteria. And if you find there is nothing else wrong, the Likert is normal, there is no reason for pathological smallness, then we have to start thinking along the lines of aneuploidy, infections, and those kind of other things.
So there is a point at which you will start investigating these babies also, because they are small, and so in a way, can I say that you are more comfortable when the Dopplers are abnormal, because at least you know somewhere one etiology is being there.
And one good way we communicate that to the patients is that we take our own example. When do we lose weight? We lose weight when we start dieting. Okay. We can also lose weight when, for example, say I have a typhoid or a tuberculosis. So you put across the same concept to the patients. The baby loses weight or does not grow if it does not get enough food from the mother, which is placental cause. It could also lose weight if there's an intrinsic cause with it, say for example a genetic abnormality, or say for example an infection. So you draw this comparison, things become easier for the patients to comprehend, I believe.
Right, that's true. Okay, so let's go on to the case now, that we have cleaned up the early and late growth restrictions. She has 2 miscarriages. She was evaluated for parental karyotyping, APL screen was normal, and she's also on ecosprin, 75 milligram OD, and she's referred for FTS at 12 weeks. So this is the report at 12 weeks. Intrauterine gestation corresponding to 12 weeks, 2 days. Corrected EDD has been given. And she said, okay, go for screening, NT is 1.5. If screen positive, you come back with the results. Are you happy with this report, or do you want anything more with 2 previous miscarriages?
I would definitely want something more, sir. That is this report as a whole, That is, the markers would have been looked into it.
All that is normal. See, I brought out the gist in the impression. Baby is structurally completely normal. So I go back to the history. She has 2 miscarriages. And anything else would you like to do at this point?
Uterine artery Dopplers.
You want uterine artery Doppler? Okay, here are the uterine artery Dopplers for you. And can we, do you think it's normal? Can you just describe this waveform for me?
In this, the waveforms are definitely, one point is there is a notching in it, but more than that, the uterine artery PI, the increased flow resistance, as evidenced by PI is 3.2 and 2.8.
Yeah. What about this little notch which you see here on both sides?
Yes.
Do you pay attention to it?
Yes. Notching
important
is
for you?
there, but that is not the absolute
Meenu?
criteria.
Meenu? How about PI versus notches? PI, notches, both. Which you want?
So we usually do not look at notches now. What we are basically worried about is the average mean PI.
Yes.
So if it is
You
more than...
are okay with the average mean PI. So, what cutoff do you use in your own clinic?
95th percentile. For the
95th
gestation.
percentile for that week of gestation. In the 11 to 14 week scan, it will be around 2.35. And of course, that's your evidence. So, now can we screen for preeclampsia in this woman?
Sir, in that screening report, I would have also wanted to see the PAPE values. In the
Okay.
screening report that you showed, you said it's screen negative, but I
Yes.
would be interested in the PAPE values as well because I'm seeing the uterine artery is high.
No, 1 minute.
Yes.
She was just referred for,
Oh, she has not done. Okay.
not yet done. So while doing, I want to know whether you can add the preeclampsia screening result for screening for her, and what are the markers needed to assess for the same. One is uterine artery Doppler. Anything else you require?
You should certainly add on preeclampsia. Just because of the fact that she is on aspirin should not stop us from screening for preeclampsia.
Because she's already on aspirin.
Yeah, so that should not stop us from screening for preeclampsia is what I'm trying to say. Because that...
So will aspirin modify your result? Will
Aspirin.
aspirin modify your result of the screening?
It does not affect the screening results.
Okay. Okay. So, and then, so she turned out to be screen positive for preeclampsia. Okay. And then her aspirin was 75 milligram. It was up to 150 milligram now. And then these are the results for you. PAPE is 0.1 mom. PAPE is 0.1 mom. HCG is 1.5. And first trimester screening positive for trisomy 13 and 18. So we were chasing preeclampsia and finally she lands up with trisomy 13, 18. How do we react to this? Yes, Bijoy?
I wouldn't be very worried about trisomy 13 or 18 because the poor placental function profile is the profile that comes out for 13 and 18. Both of them would have a low beta HCG and a low PAPE. And in this you can see the beta HCG is not that low, it's around 1.5 moms. And I'm assuming that the NT scan was definitely done well. And there were no other markers on the NT scan, so I would definitely not be worried about 13 anyway at this stage. There is a possibility of 18 presenting with very minor markers and growth restriction. That happens very rarely. But considering her history and all those things, yes, I would be worried about trisomy 18. But I'll be more worried about growth restriction and preeclampsia. And as far as NIPT is concerned, I will not offer NIPT to this group.
I understand your worry.
Yes.
Okay. All I want to know is what am I going to tell the parent? Please do amniocentesis. Am I going to say that or no?
Yes, I will.
Or I'm saying ultrasound is beautiful. I've done a fantastic ultrasound. Nothing to worry. Please go home.
Can I just argue against NIPT because I think that's important here.
Yes, please argue. I want
one
that.
important point why I will never do NIPT in this case is because it tells me that the placenta is bad.
Yes.
And therefore the cell-free fetal DNA that's going to come out from this placenta is going to be bad. The fetal fraction is going to be low and you will end up with a no result. So trisomy 13, 18 positive, low PAPE, I would not go for NIPT.
Okay.
So that's out.
So I think you brought out an extremely important point here, that whenever there is in NIPT, there is a percentage of cases where you will not get a result in NIPT. It's called no result. And this happens largely in patients who are very obese or where the PAPA is very low. So when the PAPA is very low, NIPT can fail. So there's a high chance of failure of NIPT.
Yes.
And secondly, as Bijoy rightly said, here everything is pointing towards placenta because there's a bad uterine artery Doppler there. So it's pointing towards the placenta. So they went ahead and did a CVS, and of course everything was normal. And then she was reviewed at 16 weeks. And this is the picture. Now tell us what to do. There's a 2 to 3 week lag. 16 weeks, everything is coming to around 13.5 weeks to 14 weeks.
Just follow her up again for a.
Yes?
So this probably she's going into an early onset growth restriction. So we
Okay.
can follow her up after 2 weeks again.
Okay. That brings me to a very important question. We did a uterine artery Doppler in the first trimester
Yeah.
and said this is high. Do you want to continue to keep doing this uterine artery Doppler? Is it a value in that
No,
at all?
no, sir. So that is one thing. Once we've screened the patient and we've put her into the high-risk group, I'm not going to repeat the uterine artery PI at every scan visit. But considering that her PAPA was low, she's into a high-risk profile, yes, I would put her on a monthly follow-up for growth scans, but not look at the uterine artery PI at each and every scan that I do.
Okay, at least in a fetal medicine center for your own curiosity?
No.
You don't want to do that? Okay. What about the placenta here? Are you happy with the placenta?
It does look a little heterogeneous here. It does not look very good, and it also looks a little enlarged.
So I need more placental morphological interpretation. Raymond, what do you think about this placenta?
Yeah, this looks almost similar to early onset growth restricted baby's placenta. There's this pretty small placenta, and I think I will keep a follow-up.
So when do you want her to come back?
So definitely it is 16 weeks we have done this. So I definitely follow after 4 weeks or around anomaly scans.
After 4 weeks.
Yeah.
Now comes the most important question of when to call her for follow-up. If I call her up after 4 weeks, is it going to be of any use? Am I going to make any decisions regarding the pregnancy?
But I need to, 20 weeks definitely we need to look at the...
Follow-up is for your sake or for baby's sake? For management sake?
No, anomaly scan we definitely need to call, sir. To look for the other structure.
I want everybody to answer.
Yeah,
Here's
this
the 16 weeks, there's a
particular
growth
case is
restriction.
16 weeks.
By calling her at 20 weeks, are you going to make a decision to deliver?
The
No,
20
sir,
week
it's
scan
not
would
for
be
that.
for the anomaly.
We have to rule out anomalies also. So anomaly scan we have to do because she was already high
so
risk
you're
for
going to call her for
trisomy
an anomaly scan and not for growth.
Yes.
Okay?
Yes, sir.
Okay. And if this growth is small, if you call her at 20 weeks,
Okay.
the baby will be only 17 weeks.
Yes.
So do you want to call her at 23 weeks so the baby will be at least 20 weeks size? You want the gestational age, you want the size of the baby to be around 20 weeks.
Gestational age, not
Okay.
the size of the baby.
Bijoy, 20 weeks can necessary or can we straight away go to 24 weeks where viability will come?
Sir, I think I would go for a 20-week scan. And the importance here is not just that we can't do anything, but we can prepare the mother. I wouldn't want the mother to come back after 8 weeks and tell her that her baby has become an IUD. So she's worried that this baby is small. I'm looking at this baby after 4 weeks to look for anomalies and also tell the mother what the status quo is. Because she's worried what's happening inside. I don't want her to sit with an IUD later on. Yeah.
In other words, you are worried about IUD?
I'm worried that is a possibility, yes.
Possibility. Okay. So very low PAPA, abnormal appearing placenta, high resistance uterine artery Dopplers. So placental insufficiency, early onset, very significant. So needs very close follow-up. There's risk of adverse events including IUFD. So she comes at 20 weeks, there is an IUFD. Okay? Could we have avoided this in any way?
We couldn't have avoided it definitely, but the patient will know that we did our best. That's the basic idea here, because we can't avoid this.
Okay, so her question is, when can I become pregnant again, and will this come back again? Do we have anything to offer her in terms of that?
I think you need to investigate and find out a cause. She's had 2 miscarriages already. Now this is the 3rd that's become an IUD. So you're probably thinking in terms of some unfavorable maternal condition that's precluding her from carrying a successful pregnancy. So which needs investigation, because now this is the 3rd loss, and it's the right time to start investigating for a recurrent pregnancy loss.
She hasn't been worked up for thrombophilia. She was worked up for APLA. Her karyotype was normal. We are looking at 2 early abortions, plus we are looking at unexplained, not unexplained, we know placental insufficiency is here. So I would definitely think about thrombophilia here. And I also think that needs to be worked up before she becomes pregnant again.
Yes, Shama, anything for you? Both of them.
I agree with them. I would definitely send the placenta for histopathology also. Though we have
Thank
the
you.
features.
That's why I was passing it around. I was hoping somebody will say, please look at the placenta. Yeah.
Though we have the features on the scan, the heterogeneous appearance, the small, like the others said, still the pathology is significant.
Okay. So,
But can I just little bit disagree on that?
Yes, please.
Because I know the placenta is going to show infarction and hemorrhage.
Absolutely.
Because I have no doubt that this placenta is going to show infarction and hemorrhage. My question here is, why is this placenta showing infarction and hemorrhage? Because I know this is a bad placenta, the uterine artery is high, the papae is low, and this baby is dying because of this pathology. And so when I look at this placenta, I know I'm going to get infarction and hemorrhage. So I think I would maybe save that money for the patient.
Let me answer that question for you. Yes. The only reason why we want the placenta to be examined is to rule out conditions like villitis of unknown etiology and placental maternal floor infarct. Now, if this villitis of unknown etiology, it can be a recurrent condition.
Molar changes as well, sir.
Pardon?
Molar changes as well has to be ruled out.
Molar, because of the cystic.
Because if you look at the placenta, it looks cystic. So it could have a partial
so
mode, not exactly in this particular.
I agree. If it's a classical placental dysfunction, placenta is going to show infarcts, and we are not going to answer her anything like that. But we'll be excluding certain other conditions which could be there. So let's move on to the next case. Okay, 21 weeks. AC 4th centile, EFW is the 5th centile. Uterine artery Doppler mean PI is 1.7 and umbilical artery Doppler is normal. See screen negative. Again, in the second trimester uterine artery Doppler, already you told us about that, about the cutoff values. Can we start her on ecospirin now? She's already 21 weeks. Only now you have said it. She has not had aspirin before. Can we start her on aspirin now? Because patient is very anxious and wants some treatment. My baby is small. Yes?
Yeah, it's already 21 weeks, so I think the process of placentation is over. So even if you want to start ecospirin, you have to start it, before 16 weeks, where the second wave is finished. So I don't think so there is any role for ecospirin.
So when do you want to review her now?
So after four weeks.
Same 4 weeks.
Same 4 weeks.
Same 4 weeks. Okay. So she comes. We have been screening her, and she comes at 28 weeks because we have to cut short because of the panel time. So we'll forget what happened at 24. She comes at 28 weeks. This is the growth graph. So can you tell us something about this?
Yeah, it's falling below the 5th centile, and there is an early onset to a fetal growth restriction, definitely. So I look upon the Dopplers. The first thing, if I diagnose the fetal growth restriction early, then the next thing is I look upon the Dopplers.
So what Dopplers do you want now?
So basically, umbilical artery Doppler is the most important tool I looked upon.
Ma'am, you take it up and say what all Dopplers you will do in this case.
Definitely the umbilical artery Doppler, metacerebral artery Doppler, the ductus venosus.
You want everything. You want all the Dopplers.
If the umbilical artery Doppler is abnormal, I'll do the ductus venosus.
Okay, so now comes a question. If I do the umbilical artery Doppler and umbilical artery is absolutely normal, do I need to do the MCA and DV?
No, sir. Actually, in early onset IUGR, the earliest changes starts in the uterine artery, the
So
uterine
uterine
artery
artery
and
done.
the
Already we
middle
have
cerebral.
done it.
Yeah, and
Yeah.
the middle cerebral artery also, the earliest changes
Yes.
occurs in the middle cerebral
Because
artery.
this is a very, very important question that I need all my panelists to concur on this. Bijoy, umbilical artery normal. Do you want to do middle cerebral artery at all?
Is the question want or need? If it is want, I will do everything. But need, if you're asking me about do I need to do it, I don't need to do it, because if the umbilical artery is normal at 28 weeks, I'm not worried about cardiovascular
So in
adaptation
other
or
words, what
MCA.
you're saying is, when the umbilical artery is normal, it is impossible for the ductus venosus to be abnormal.
Yes.
Agreed?
Yes.
Okay. So there is a 3 to 4 week lag at this point of time. MCA Doppler is normal, DV is normal, and so now can we stage? Is there something known as staging the growth restriction at this point? And do you believe in staging? Yes, Meena.
So definitely staging is very important because it helps us to decide how frequently we need to monitor. So based on these findings where I have IUGR and the umbilical artery Doppler is high PI, I would like to classify it as stage 1 IUGR.
Uh-huh.
Yeah,
So,
and-
yeah, that's your stage 1. And what do you do? Why is it important to stage?
So-
What information does it give
So
you?
because depending on the staging, it will help me to decide how frequently I need to see this patient and till what time I can carry on this pregnancy in utero.
Okay, she's 28 weeks now. When do you want her to come back?
After a week, because I see her in stage 1 IUGR, and therefore I would like to see her, considering that there are no other maternal comorbid conditions that I'm dealing
So
with.
1 week later, finding is the same. No change.
Yeah, so I continue with the weekly
Continue with the
follow-up.
weekly Doppler. Okay, so she comes to 30 weeks and 2 days, and this is her picture. Okay?
Yeah.
So you're
Now
fine.
she's
Yeah, go ahead.
You're finding that the umbilical artery flow is absent during diastole. There's no waveform during diastole, but the middle cerebral artery, there is slightly more flow in diastole. So it's kind of telling us that there is a kind of compensation that's happening. The baby is trying to restrict blood flow to the less vital organs and push more blood flow to the brain. So absent end diastolic flow, if you go by the criteria, falls under stage 2. So now it's upgraded to stage 2, rather
from
downgraded
this,
to stage 2.
In 2 weeks' time, she has gone from forward flow in umbilical artery to absent flow. Does it tell you anything about
It's
is
kind
this a
of-
very severe condition or
Yes,
it's a mild, moderate, something like that?
No, it is mirroring the placenta because we know the fractions of placenta that need to be abnormal for the umbilical artery to show an abnormality.
So now that she has come to stage 2 and she's already 30 weeks and 2 days, why can't we can we ask our neonatologist? My neonatologist says, my NICU is top class, world class. Give me 24-week baby, I'll save. 30 weeks is cakewalk for me. Please give the baby now. You want to pull it out?
No, sir, because what we have to understand here is that fetus is still in the stage of hypoxia, but we are not dealing with something like a severe acidosis because of which we need to take out the baby at this gestational age, even though we find that there is absent end diastolic flow. So we can still monitor this, increase the monitoring, increase the degree of surveillance, and try to push it further.
So what about steroids now then? No.
They don't give in my institute, so I would say no.
Vijay?
Yeah.
Steroids at 30
No,
weeks.
yeah, for me, steroids is the last thing that you will give when you decide to deliver, not now when we think that there is a possibility of
So
delivery.
in other
happening.
words, you are saying there is an absent diastolic flow in the umbilical artery. It has moved from stage 1 to stage 2, but I am not interested in delivering the baby.
Yes,
Why are you saying that?
because this baby is having hypoxia. We know that it is hypoxic, but we have to compare two things here. One is the extrauterine environment in lung maturity and the intrauterine environment where there is a possibility of intrauterine demise. So with hypoxia at 30 weeks, I am happy to wait till there is acidosis, and I would wait a little bit
So
more with more.
let me put the question completely different. What will make you deliver?
A DV reversal at this stage would make me deliver, or an abnormal biophysical profile, or an abnormal CTG.
So you want
It's about
Or-
deciding which
or-
is the greater evil.
Yeah, and mother.
It's about deciding which is the greater evil.
Yes, yes, and
Because
mother
prematurity
also.
is as bad as, at times even more bad or worse than.
So
And-
my
and
entire
hypoxia.
panel is saying, don't deliver now.
And one more point, sir. This accelerated pretty fast. So 70% of early onset growth restriction will have preeclampsia. So because it is accelerating so fast, the mother's condition is also something that we have to keep in mind.
So now I'm going to hold you to it, because in 1 week's time, okay, she comes back with IUFT. Will you take responsibility?
Again, I would like to stress one thing about the staging part.
Yes.
Which everyone understands, that when we talk about staging,
Yes.
we should also understand that there is a thing called as a safety net. Whenever we say use a staging protocol, call this baby twice in a week, we are only talking about the bare minimum.
Yes.
The bare minimum. So when I'm looking at stage 2 FGR, the bare minimum is to call them twice in a week to do ultrasound and look at Doppler. But I will be looking at their CTG and biophysical profile almost daily. That is the safety net.
Thank you
and
very much.
If this patient came back in as IUFD 1 week later, there is no one else to blame except us.
Okay, thank you very much. I think this was an extremely important point to be brought out, that we fix our eyes on Doppler, and Doppler DV is normal, and suddenly we leave out the fact that the baby is actually deteriorating, and we should not let loose of that. So why are we want to buy that time? Once it crosses 30 weeks, the neonatal survival rates exceed 90%, and every week gained we get about 13% additional follow-up. So the patient was on routine follow-up. What the key things to assess the clinical assessment, as you rightly said, her BP started varying came to around 140/90, protein was nil. Now, do you want to call her bi-weekly instead of weekly now? Because she's already gone to this level.
Well, in the setting of a maternal illness like preeclampsia, none of these rules apply, sir. So we cannot really go by the 1 week, 2 week follow-up
Can't
protocols.
that. So it's on a daily basis,
Yes.
right?
And you would, of course, as Dr. Bijoy said, you will always use the safety
So we
net.
managed to push her to 32 weeks and 3 days. And umbilical artery Doppler, absent end diastolic flow, occasional reversal. Occasional reversal. Suddenly, as I'm running something, if you are reversing, then comes back to absent. So
think
biophysical
there's no-
profile score is 8 out of 10 at this point.
I think in singleton pregnancies, we do not encounter something called as occasional reversal.
Keep it closer, please.
So in singleton pregnancies, we do not really encounter something called as occasional reversal of flow in the umbilical artery. So it has either to do with
intermittent. I'm saying about intermittent.
even intermittent, I think it's either to do with the fact that there is too much of movement, maternal breathing, or the settings that you're using on ultrasound. I'm talking only about intermittent reversal is only there for twins, monochorionics. It's not there for singleton pregnancies.
Oh, she says I made it up.
No.
Actually, it was there. Okay, so no problem.
I think
So,
what sir is saying.
all I want to do is
different
there
portions
a
of-
trigger for delivery now?
I mean,
See? Shama?
Yeah, there is, I think, better to get the baby out.
Everybody agrees? I have
Yes.
yes.
Yeah.
6 on 6, deliver now?
Absent
Yeah.
end diastolic flow.
Yeah.
So there's already absent and diastolic flow, and I don't think so
Anybody?
there any role
One
of-
more week.
She's reached
Can
out.
I understand the prematurity is a problem. Prematurity is a major complications. I counsel the couple and I'll plan better for the delivery.
Okay? Right. So, now the question of steroid cover. Now will you give steroid?
Yes, absolutely. Before delivering, I will give steroids. And
So this
we'll wait.
patient was already given steroids at 30 weeks. That was the reality. She was already given at that time. Do you need to repeat it?
One problem with giving steroids early is that it can change the biophysical profile, it can change the Doppler, and that effect lasts for 7 weeks, 7 days. So when you give steroids prematurely, it takes off the only tools that you have to monitor this fetus. Your biophysical profile will be different, your variability will be different on your CTG, you are not going to get the Doppler sequential changes, so it masks that. Now, it is good also because if you see that masking effect because of steroids, it tells you that this baby's heart is good, but then that's a totally different story. I'm not going there. But if they have already given steroids, and if this happens, I would give a rescue dose. I would definitely give a rescue dose if it is coming from outside or something.
Okay. So she was, cesarean was done, 1.15 kg, was in NICU for 2 weeks. Now 6 months old on follow-up with the pediatrician, and so far doing well.
So just one comment I just
Yes.
want to make on why the neonatologist says that take the baby out at 30 weeks and it's okay, there is no need to wait. They are justified in saying that because they feel that we do not deliver at the right time. Because if you deliver at the right time, the baby won't be acidotic at birth. When we miss that bus, we wait, we think, just like in this case, we say it is in stage 2, we call them back twice in a week, and then finally we find there is DV reversal and the baby is acidotic with tricuspid regurgitation. It's because we were not closely watching this baby. If we are taking the responsibility of pushing this fetus in utero, we have to watch this baby very closely and deliver this baby before this baby decompensates. And most neonatologists will tell you that I'm getting a baby that is decompensated, so what's the point in your grading system and IUGR management? So they are justified there because we have failed to actually take the baby out before it is acidotic. So they would feel, why give me a bad baby, take this out at 30 weeks. So if you do not have the facility to monitor this baby very closely, when the baby is acidotic, hypoxic at 30 weeks, I would definitely say that better refer the patient or listen to your neonatologist.
Yes. So that the question now comes is, does ductus venosus dictate delivery or neonatologist dictates delivery?
A good fetal medicine specialist should dictate delivery. That's my opinion.
So you're somewhere in between. Okay, so let's go on to this case now. Target scan 19 weeks, everything is beautiful, going on very well. So she's a primary low risk normal growth at 19 weeks. Do you routinely advise growth assessment for all? If so, when do you assess? She is absolutely low risk. Nice uterine artery Dopplers are excellent. First trimester screening is normal. Everything is normal. Next scan. Yeah.
So if everything is normal, I don't advise a growth scan in between. I do a third trimester growth scan only.
At what time?
Around 34 weeks.
34 weeks.
Yes.
Agreement, disagreement?
34.
I better will do, around 36 weeks.
36.
36,
So
that will
34,
be more
36.
ideal.
Yes.
The premise for that is that, say, your obstetric hands, the obstetrician's hands are sensitive enough. Because I am trying to pick out a baby who's becoming growth restricted. The best time to do a scan, of course, would be 36 weeks because we do not want to miss out on the late growth restrictions. But having said that, I must make sure that my obstetrician has been palpating her regularly and her symphysiofundal height measurements have been proper, and there's no suspicion of a growth restriction in the first place.
So that's what I'm saying. She is low risk, there's no suspicion at all. So she can go to 36 weeks. So I have two people 36.
I would go one step further and say that she will need 2 scans. One at 32 weeks to look for late onset anomalies and also growth. So anyway, you need one at 32 weeks to check out for normal anomaly scan at 20 weeks will not rule out late onset anomalies which can have a change in her perinatal outcome. Simple example, diaphragmatic hernia. You can totally miss it at 20 weeks. The hernia may be seen at 32 weeks. So 32 week scan is definitely a must. Along with that, growth should be done. And then another just growth scan at 36 weeks. So I would go for 2 scans.
Let me play the devil's advocate there. Diaphragmatic hernia incidence is 1 in 5,000. So I will do 5,000 scans at 32 weeks to find out that one diaphragmatic hernia.
That is just one of the, example.
In that case, would you want to call it 28 or 32?
32, I'll tell you why 32, because at 28, even if I make a diagnosis of a late onset anomaly, there's no need for me to make that diagnosis at that point. I can very well make it at 32. Because at 32, I'm perfectly happy that, there is nothing wrong with the baby.
No, but again, it comes back to the same problem that we discussed before. You see a mother at 19 weeks and say everything is normal. She comes back at 32 weeks and suddenly you break a bad news.
No, breaking the bad news is not the issue. For making the mother prepared for what is going to happen later on.
So,
at 36 weeks, it's too late for them to get counseling, to be prepared for delivery and all those
36 are
things.
great. Question is about 28 versus 32. Which would be a better choice?
I would still prefer 32 because growth can be assessed better at 32.
Okay, so let me put one question. She's again very, very low risk patient, nothing at all, no family history, nothing. Only thing that has happened is her uterine artery Dopplers have been abnormal at 20 weeks. During the target scan, her uterine artery Doppler alone was abnormal, but growth was still normal. Her biochemical parameters, everything has been normal. So will you also call her at 36 weeks or 32 weeks or at 28 weeks? Is there an indication to call her at 28 because of the uterine artery
So
Doppler?
that would be an indication to call her back early for a scan, because the uterine artery PI being abnormal at that point of time would reflect that, probably this placenta is not good enough to support once the baby becomes bigger.
Okay.
So probably that subset would what we would want to call a little early at 28 weeks and not 32.
So
or
28
36.
weeks.
Yeah.
Sir, everybody agree? With the uterine artery Doppler, you'll get her at 28 weeks. And that. Okay, let's see what happened here. So she was advised a growth scan at 28 weeks. Even though the uterine artery Doppler was normal, they still said 28 weeks. And they were not, it was, Bijoy's thing was 32, she should have come at 28. And seems good, isn't it? Seems quite good at 28 weeks. You can see the growth. Okay. So, with normal growth velocities at 28 weeks, should we need further scans at all? Now that we have said she's going on course, okay, take a train, go to your mother's place, enjoy yourself.
No, she cannot do all that, but then she has to come back at 32 weeks for a growth
Again,
scan.
you want 32. Now, here's a normally growing baby. Why do you want to keep pulling her back?
Because it's like, I think the example that I always give is breastfeeding and a small neonate. Till 6 months the child is okay, but after that the baby needs more and breast milk is not enough and the child is going to growth restrict.
So
the same
Bijoy
thing, the placenta is good enough till 28 weeks, everything is good. But if there is a problem with the placenta, it will start reflecting late. It will start reflecting at around 32 weeks and sometimes very late at around 36 weeks.
Anyway, I'm glad you're sticking to your point. What Bijoy says is, who asked you to come at 28 weeks? I asked you to come at 32. It's not my fault, so you come at 32. Okay, right. So she came for 34 weeks review, and this was the growth. Okay, the AC dropped from 30th centile. It was on the 30th centile, then it went to the 8th centile. And of course, when she started off at 19 weeks, it was on the 50th centile. So are we raising alarm here? Are we going to call this a growth restriction? And you can see the Dopplers. Yes? What to do? Is this baby growth restricted?
No, we won't call it as growth restricted, but definitely we'll increase the surveillance.
Sir, 1 minute. The definition of small baby or growth was when the AC or estimated fetal weight below the 10th centile. So this AC has come to 8th centile. So 8th centile, I'm not worried. But 10th centile is my cutoff. So how do we interpret that? Is there not a trend of dropping? Are you not concerned?
No, there is certainly a dropping trend, and the baby is small because the AC is less than 10 centile. But from the Dopplers that you have shown, what is missing is probably the MCA Doppler. The umbilical artery Doppler looks normal, which it could in late onset growth restriction. But
So the Doppler is putting you in the comfort zone.
not until I know the MCA Dopplers as well and the CPR as well.
So we have still not come to the diagnosis yet. So
did you say that the centile was at the 50th centile?
from the 50th, it came to 30th, now it comes to 8th.
20th. And at some point, I think you mentioned about the uterine artery? No.
No,
That was
uterine
a parallel.
In this case, it was normal.
It was normal.
Normal.
Okay.
Okay, all this we have seen. So she comes to 34 weeks now, okay, and 34 weeks and 3 days, something like that. And the AC is the 5th centile, umbilical artery, Doppler, DV normal. So you can see are we going to call this as late onset growth restriction or no? This is all I want.
Well, strictly as per criteria, not yet, sir, because there is some information that's missing here.
Pardon?
There's still some information missing, because we need to know the oxygenation of the baby.
So
Really?
what information you want, you ask me, I'll give you.
I need to know the CPR at least.
Oh, you want CPR? Okay.
Because if you go by criteria, there is a drop in growth from 50th to 8th centile, which is still not 2 quartiles.
You know what? I didn't get trained in CPR. Okay. I know umbilical artery Doppler. I've done middle cerebral, and middle cerebral Doppler looks normal to me. And DV is also normal, but the baby is grown smaller. So am I going to call this as growth restriction or no? Do I need Doppler to tell me it's growth restriction? Or in other words, is CPR essential for diagnosis of late onset growth restriction? Or is it a decision-making point, or is it a diagnostic point?
It is a diagnostic point, and here that is what's missing, and that's what's putting everyone on the fence as to whether to call this baby FGR or SGA or not.
Thank you.
But for me, one more point, sir. Just let me finish that point. If this baby is dropping centiles, it doesn't matter what name I give to this baby, FGR, SGA, whatever, I'm going to put this baby on follow-up. And I think that's what's more important. Whether we label it as FGR or SGA or whatever, this baby is dropping centiles, was at the 50th centile, has come down to the 8th centile. I would be worried, and I would put this baby on follow-up. That's all.
So if the baby is kicking well and the liker is good,
It doesn't
tell the
matter.
mother, you come back again, forget
Yes.
about everything else.
Yes.
Okay. So is this a reason why almost 50% of late onset growth restrictions are missed on the ultrasound?
Absolutely. And 40% of your stillbirths are going to be late onset FGR.
Okay, now I'll give you middle cerebral artery Doppler. You asked for it. She's come to 35 now, and the umbilical artery is showing a little bit of absent flow there. And you can see the MCA Doppler. And the CPR is 0.52.
Sir,
We don't need the MCA.
sir, I am a bit surprised that the umbilical artery, which is showing such good diastolic flow,
Yes.
has accelerated into absent end diastolic flow.
Exactly.
It is something very weird that's happening
So
there.
maybe baby is holding its cord, or there's a knot in the cord or something like that. I don't know. Because we were also surprised. So all I'm trying to bring forth is, suddenly you are faced with thing. My focus is not on the umbilical artery there now. My focus is on the CPR, as you rightly said, and she's already 35 weeks. Should we just deliver?
Absent end diastolic flow. I'm sorry.
Everybody voting for delivery? Yes.
Yes.
Ma'am?
Yeah, she's already 35 weeks.
35.
Absent flow in umbilical artery, we should deliver with
Because
CPR.
if I don't deliver now, my neonatologist will get very angry.
Yes, the baby might go for IUD.
He is already angry.
He's already angry. That's what I'm saying. He's been telling from that time, but give it to me. Okay. So I think it's an important point that there is cerebral redistribution, late onset growth restriction.
Can I ask one question, sir?
Yes.
You showed 32 weeks before, no, 34.
Yes.
So this change has happened in 1 week.
Yes. It changed happened in 1 week.
And this mother did not have any preeclampsia, nothing.
No, she didn't have anything.
No abruption, nothing.
Yeah, she
Absolutely
was very
nothing.
comfortable. She was very comfortable. We called her weekly because we saw the trend going down and said, you better come. Okay. So
one thing, so I think one thing that we have to, just important is that it's important that we look at the falling growth trend. Even though it does not fall into the definitions now, since we have a criteria that is there, Delphi consensus, even if it does not follow the fall of the growth trend of more than 2 quartiles, and you see that there is a falling trend, it is important that those kind of fetuses are put under surveillance, irrespective of the fact whether it is significant or
correct.
not.
So delivery was planned and 1.6 kg baby was done. NICU admission for 7 days and the baby is doing well. The trend is very, very important. Whether it's a Doppler or whether it's with growth, the trend is very, very important. So
Can I ask a question, sorry, from
Yes.
the audience? When they spoke about early growth restriction, you mentioned CTG and biphysical profile. Now here we have a late onset growth restriction, 34 weeks. The trend is falling, but I didn't hear any of you talk about CTG or AFI.
Absolutely a must. When you see the baby's growth is falling, and you're calling, that's what I said, I would have put this baby on follow-up. And my follow-up in this case, where the baby's trend is falling, would be three things. One is CTG, the biophysical profile, and also asking the mother to look at the fetal movement count. So if these three things were in place, probably my neonatologist would have been a little bit more happier, because then we would have delivered this baby slightly a bit more earlier. Because before you get that kind of a finding, I'm sure there would have been some signal that would have gone off in the biophysical profile or the CTG or the fetal movement count.
I think Bijoy's message was very clear in the beginning, that you always look at the baby as a whole. It is not just ultrasound. There is another component where you do all the other routine tests and you combine this with these results, and then only you take it there. Right. So I think we're only about 4 minutes more. Just a very, very quick one. This is a IVF pregnancy. She's a twin at 9 weeks. You can see obviously it's a dichorionic twin. Referred for 20-week anomaly scan. Both are structurally normal. At 20 weeks, there's a discordancy of 25% between the two. Okay, I'll quickly rush through this. Do you need anything more? These are the graphs. You can see 25%, but both of them are growing. And the Doppler centiles were normal at this stage. So 4-weekly growth, and at 24-25 weeks, the discordancy increases to 36%. Okay, and then there's a 36% discordancy, and you can see what happened to the umbilical artery. It has suddenly shot up, and she's 26 weeks for this one baby. And this is your Doppler. Fetus A is showing absent diastolic flow. She is 25 weeks, and the other baby's Doppler is normal. Are we going to do anything about it? Just follow up.
I think we should prioritize for the normally growing twin.
Okay. So at 28, 29 weeks, the baby is even smaller. As you can see, it growing much smaller. And you can see reverse diastolic flow. So from 25 weeks to 29 weeks, the smaller baby has got reverse diastolic flow in the umbilical artery. Should we just deliver? And the DV is not absent flow, but it's showing high resistance flow.
Shall I? Or? Okay, sir, I would deliver this baby right now, because now you're saying 31 weeks, no, sir?
No, she's now...
29, no. If it's 29, wait. 29, wait.
Wait.
Definitely wait.
Okay.
I would want to ensure that the normally growing twin is healthy before I take out the...
normally growing baby is very, very healthy.
Yes.
Yeah, but it has to reach a certain stage of normal neurodevelopmental outcome.
So what's your comfort level? What's your comfort level for the normal baby to be delivered?
I think 30 weeks plus or 32 weeks if possible, at least 30 weeks.
So 29 weeks we'll follow up. Okay? Right. So 28 weeks plus 4 days, you can see all the Dopplers are going haywire. Then at 32 weeks, okay? At 32 weeks, so the decision was discussed with the family, saying this baby is really progressing badly. Risk of IUFD to the fetus A was informed, and risk of prematurity. The couple said, if my normal baby is going to go to the NICU, I don't have money for it. I can't spend. Okay? So wait. So at 32 weeks, fetus A becomes intrauterine demise. Okay? Now single fetal demise in DCDA twin. Now what do we do?
Just continue as a singleton. There is nothing else to worry as far as the mother is concerned.
So nothing else need to be done. Yeah. So she delivered by LHCS at 37 weeks, and then that baby was all right. Now my whole question is, at 32 weeks, just before that demise, could we have delivered both and got away with it?
So for us, what we follow is, if the DV reverses before 30 weeks, or if you have a severe abnormality before 30 weeks, we don't touch the baby. 30 to 32 weeks, if the criteria are met for singleton delivery, that is, if you have a reversed end diastolic flow in the umbilical artery, then we do deliver. But if the baby is showing severe signs of hypoxia, the small baby, at 32 weeks, they are showing severe signs of hypoxia, then we would decide to deliver. And if you are sure that we can salvage the smaller baby, if the smaller baby at 32 weeks is really bad, for example, there is tricuspid regurgitation, pericardial effusion, then we leave it, we don't deliver. But if the baby is reasonably okay at 32 weeks, then we take a decision for delivering both those fetuses.
And do that.
Yeah.
So optimizing outcome for both is the goal.
Yes.
But if you are given a choice, the choice weighs heavily in favor of the
Now,
normally growing baby.
one caveat in this.
Yes.
Caveat in this is that if we decide to continue with the two babies and thinking that the smaller baby will die, a small proportion of these smaller babies may not die.
Yes.
May not die. So at
Yes.
36 to 37 weeks, when you deliver these fetuses, you may land up with one baby that is having cerebral palsy.
Neurological.
So
Yeah.
that has to be also counseled. So when we are saying that this smaller baby will die in utero, that is what we are thinking is the normal trend and can happen. But some of these babies do fight it out and they do reach 36 and 37 weeks, and then it becomes a difficult point at that time.
Sure.
So counseling should include that as well.
Yes.
Yes.
Thank
Yeah,
you
I
very
think
much.
ultimately
We have
parents'
run out
choice.
of time.